Hello, everyone. My name is Dr. Gabrielle Jones. I'm a licensed psychologist and clinical services supervisor for Rogers Behavioral Health San Francisco East Bay Clinic. We're so glad that you could join us today for this virtual panel discussion on managing OCD during the pandemic with some of our lovely experts. It is my pleasure to introduce the panel that will be talking with you today. We have Dr. Lindsay Bergman from our Los Angeles clinic, Drs. Brett Johnson and Sanjay Saxena from San Diego Clinic, and Dr. Jennifer Park from our San Francisco East Bay Clinic. Welcome, everyone. So great to have you here. We're going to jump right in with some questions. And for those of you viewing today, remember, if you have any additional questions for our panelists, please comment with those and we'll do the best we can to answer them at the end. We'll also be sharing some national and local resources for you at the end of this broadcast. So let's get started. Question 1. What can you tell us about how someone struggling with OCD prior to COVID-19 and now during it is different?
That's a great question, Dr. Jones. What I've actually found is that there's been a lot of variety in terms of responses and how people have kind of struggled post-COVID pandemic times. When we're talking specifically about OCD, some of the folks that I've worked with that don't really struggle with kind of the contamination or, health anxiety portion of it are like, it's just kind of like regular, the way that, a non-OCD person might respond to the pandemic, some added stressors and whatnot, but no real change necessarily to their OCD per se. The folks with some contamination issues, and some health anxiety, I've seen kind of a split. I've had some patients actually say, I've been ready. I've been waiting for this my entire life. I've got a garage full of hand sanitizer. Bring it, And so part of them have already been, and kind of validation too, right? This sort of feeling of, hey, I told you guys, told you so, this was happening. So there's that piece of it. But of course, we also see kind of like the really severe responses, the really severe anxiety, people who were not homebound before are now homebound. Some folks are even scared to like open windows, so really kind of going above and beyond in terms of the way that they might respond to another type of maybe a flu season or other type of season that might come through. But I think one of the things that's kind of constant all across, regardless of, OCD symptom type, is really the kind of general stressors of the pandemic, talking about job loss, social isolation, the uncertainty of what's to come. That's really impacting everybody, all across, OCD or not. You see these added stressors to our OCD population, and that anxiety increases and that distress and that impairment increases quite a bit. So I think what we've seen is a real rise in mental health issues in general, not really just specific to OCD.
Fantastic. Thank you, Dr. Park. The next question that we have is, how has COVID-19 impacted the treatment for OCD?
I think Dr. Park did a great job explaining some of the factors that really come to the forefront, in terms of having entire families have not only, uncertainty about illness, but oftentimes day-to-day things, food and, is this safe? In certain places, conflicts over even wearing masks. And especially, in terms of, contamination OCD, I think in terms of treating it, it really depends on the nature of the contamination OCD, but we've all had to shift our practices, a little bit. It's much harder to do certain types of exposures just because, of the risks of COVID. At the same time, I've seen increased creativity on, in the staff and coming up with ways around it, whether it's, what we call imaginal exposures, or, sort of imagining different scenarios or worry scripts. I tend to be an optimist, and I think most people in child psych are. So I've actually seen some really good impacts on it, actually. There seems to be much greater parental involvement. Oftentimes parents are working from home. I have seen more fathers involved in their child's OCD treatment than I've ever seen before, which is absolutely fantastic. The other thing that is both good and bad, a lot of services have flipped to telehealth model, in terms of helping to mitigate the infection risks, and what we've actually seen is that even though people were saying this can't be as good, preliminary numbers from at least us at Rogers show that it is almost nearly as good as in person for most cases. The thing that got me really excited, though, is the ability to branch out and do telehealth services for more remote areas. I tend to come from a smaller, more rural part of the country. In California, I mean, our clinics are, of course, based in the larger cities, but we've been able to do one of the families I treat is about 2 hours away from either the LA clinic or ours in San Diego, and being able to serve more people, I think, actually has been a positive of that.
And I'm actually curious as to what the other panelists have kind of experienced in regards to this in terms of the challenges of treating OCD during these times, because one of my biggest challenges has been combating misinformation, and the fact that there's so much information, and how do you filter through it, and how do we impart to the patients and clients that we work with what information they should be listening to. I know I had one patient say to me, I've been watching this video, and my family's been watching this video of this doctor of how to take care of your groceries when you bring them back from home. And she said to me, she goes, "But Dr. Park, I think this doctor has OCD because this is too much." And I was like, "Yeah, you're right." And she's like, "But because my family has seen it, they now think we should all be doing this." So it's been this really interesting sort of balance of trying to figure out how do we stay safe, filter out the information that we need, and then combat a lot of what's happening, because I have found myself getting into a lot of negotiations, if you will, with my patients to be like, well, maybe we don't listen to them, or maybe we limit what we listen to. But it has been a challenge, especially because the information, even on an expert level, changes almost day to day or week to week. So, I mean, I'd love to hear if other panelists have had that experience as well.
Yeah, I'll jump in. Thanks, Dr. Park, for bringing that up. And Dr. Johnson, what you're saying too is I've had those kinds of discussions and negotiations and kind of probing as to how people are justifying their compulsions, but it's been on all sides. Some people with OCD, or even patients without OCD, maybe with other anxiety disorders, but now are developing kind of new onset de novo OCD style symptoms as just part of their response to the stress and the issues of the pandemic and the lockdown. So for some of them, they're going way overboard, as you're pointing out, washing all their produce with soap and water after bringing it home from the grocery store. People changing their clothes every time they leave the house and come back in the house. It might be 6 times a day, and they're still doing that. I've also had patients who went the other way. I had a guy just yesterday, a young man who wanted to do his own exposure. So he went to a party where there were about 15 people in a house, none of whom were wearing masks, none of whom were distancing. He thought that was a great idea. Great contamination OCD exposure. And we had to, again, correct the misinformation and try to draw appropriate boundaries as to really what was safe and what was not safe in a way that you don't usually have to do when there's not a pandemic.
Dr. Bergman, would you like to add to that? You're muted.
I would just say there's also a lot of confusion, I think, nationwide about what's okay and what's not okay. What Dr. Saxena just described, going to a party unmasked, we saw that happen in Washington, basically, and cause a lot of infection. So it's really difficult to know, was that an exposure, or is that accepted? So I would agree that it's really difficult to know what to tell patients is okay or not okay, and they come in and ask, and in a situation where you're also, what we all do here at Rogers, a lot of times we're supervising therapists in how to treat OCD and how to help with these contamination issues, where most of the time patients are going overboard in what they think they need to do, and some of the things that they're doing that the patients are doing are things that we may have all been doing at the beginning of the pandemic, but the rules were later changed, and it's pretty confusing.
Thank you. Speaking of what to do, that leads us very well into our next question. What are the types of skills or exercises that you coach patients and their families to practice at home after their treatment's completed for the day to help them continue their recovery at home?
I can, answer that. I think that's a great question, Dr. Jones. I think it's important to understand that as people have alluded to, the impact of the pandemic differs from patient to patient. It differs for different aspects or different groups in our population. So I think one thing that we as clinicians, but also family members and people with various disorders, have to think about what are the best ways to cope is, first of all, think about who's impacted more. Who's likely to be impacted more, because one of the things we have to do is to watch out for particularly vulnerable groups and recognize warning signs. So we know that, from studies that have been done all over the world, and particularly ones that have been done right here in our country, that certain groups are at the highest risk for the most adverse impacts, particularly most adverse mental health impacts of this pandemic and of the associated restrictions, meaning increased anxiety symptoms, increased depression, and even suicidality, increased substance abuse, increased traumatic stress symptoms, as well as the socioeconomic problems. So people with pre-existing psychiatric disorders, even prior to the pandemic, are much more likely to now be having problems over the last several months that are much more severe. People who contracted COVID infections themselves, right, had to deal with the physical health consequences, but also a tremendous number of previously unforeseen neuropsychiatric and mental health consequences just of having COVID. Particular demographic groups, so 18 to 24-year-olds, right? What we would call as clinicians transitional aged youth, in that zone of life where social involvement, getting jobs, working, being in college, etc., is really critically important, and that's what's been disrupted the most. So 18 to 24-year-olds have shown the highest rates of anxiety, depression, substance use, and other distress symptoms during this pandemic. Women more than men. Even particular professions, nurses in a couple studies, had the highest risks. Healthcare providers overall, but particularly nurses who are on the front lines, had the highest rates of traumatic stress symptoms, anxiety, and depression. And then those people who had family members, relatives who had COVID, even those who may have had a family member pass away or be seriously ill in the hospital, in the ICU. And then lastly, those who have the greatest socioeconomic vulnerabilities, so people with lower incomes, lower educational status, who don't have access to the right information or to proper medical care, those who are more isolated, those who may be more ill themselves. So there are general principles for how to cope that I think apply to everyone, but they apply differently to folks, I think, who are in better situations where they have more protective factors, greater age, greater amount of family support, greater amount of economic and medical resources to rely upon, more, who are taking the precautions. Those are protective factors. In a general way, while we want to maintain physical distance, we need to increase social connection, right? So right from the very beginning, been advising people to stay connected with people as much as possible. Use Zoom, and Teams and FaceTime, and hook up with friends and family members in other parts of the country and see their faces and hear their voices. It's a good sort of balm to soothe you when you can't actually be with people in person. Secondly, setting consistent routines, sleep-wake cycle, eating patterns, appropriate boundaries if you're working at home between work time and family time, because those can completely blend together, right? I think we've noticed that. Maintaining exercise, right? Keeping yourself physically fit. Doing stress reduction, self-care, mindfulness, relaxation exercises to deal with the heightened level of tension that, the entire world, if not certainly the entire country, is dealing with. And limiting news coverage and internet exposure. I remember early on, I, like lots of people, were glued to the TV or glued to the internet, catching up on news and watching the case counts and the death counts day after day, after hour, and it is overwhelming. And in fact, it turns out it's bad for people. So the amount of coverage that we're exposed to does have an impact on how distressed we are. So it's appropriate to limit it and set some boundaries there as well, and make sure that it's accurate information, not conspiracy theories. Limiting the use of alcohol, tobacco, and drugs, because we know that that's elevated, right? Over a lot, not just people with pre-existing substance abuse, but lots of other folks in the general population are just drinking a lot more, using a lot more, smoking a lot more. And that's one of the warning signs that family members should be looking for in their loved ones, and then seeking help when these warning signs occur. So for parents, checking in with your kids, communicating, finding out how they're doing, because they're not going to necessarily express it in the same way that an adult would, right? And our child and adolescent experts on the panel can probably speak to this better than I can, but maintaining that communication within family groups and friend groups, and using the resources. So there are hotlines available, there are warm lines, there are mental health resources of all different kinds, not only us as mental health professionals in treatment providing settings, but also online resources, support groups, etc. Some of the resources that we'll talk about towards the end as well.
Thank you, Dr. Saxena. Would anyone else like to add anything before we go on to the next question?
Well, I just wanted to say that I really appreciated Dr. Saxena talking about the socioeconomic and racial disparities that have come up during this time as well. I think, we talk about, and this really, it's both the impact of COVID on these populations, as well as the impact of mental health. So it's a double whammy, if you will. I think that it's really important for us as healthcare providers, mental health providers, and for, our, folks, community members, to be aware that, a lot of the times it is these folks who are that have lower socioeconomic status that are placed in kind of more dangerous positions where they can't stop working and they can't quarantine. Or, they're not able to, they have the jobs where they're doing deliveries, where they're in contact with a lot of people. Sometimes these public health measures that are being rolled out, as much as a person may want to follow them, they may not be feasibly able to follow them due to the constraints of their lives and their situation. And then given the, access to care issue that has kind of oftentimes occurred, and, so when they get sick, whether it's due to mental health or due to COVID, where do they go? How do they get the appropriate treatments? And I think that it's important for us to continue on this discussion as mental health providers. So I really appreciate Dr. Saxena kind of just highlighting that while talking about skills and coping.
Absolutely. The next question is, what has been the biggest challenge that you think has occurred for those who are being treated for OCD during the pandemic?
I'll address that. Well, OCD really thrives on uncertainty. And one thing that the virus has in abundance is uncertainty. Early on, the uncertainty was related to just not knowing what's going on, how the virus is transmitted, what kinds of symptoms show up and how soon, and who's most at risk. And then as time went on, the information that we knew changed. And I think what's happened is, so, early on, we were very concerned with surfaces and cleaning surfaces. And I think everybody, whether they were particularly anxious or not, was wiping things down like crazy, and, including their groceries and packages. And then, and we didn't think it was airborne. And then it became that, that you were more likely to get infected from a sick person than you were from surfaces. And most people stopped wiping down their packages. And then one thing I've noticed is that people with OCD might still be doing that, wiping down their packages and their groceries. And the uncertainty became more about when guidelines changed. And it wasn't, so it's a good thing that like public health guidelines have changed, because they really changed because of new information, not because of uncertainty. But what I see is that people with OCD, because it's a change, they're less able to adapt to those changing guidelines. And there's still a little bit of uncertainty. So somebody with OCD wants a promise that there's no way that they could get the virus from their mail or from the groceries. And you can never promise that. And so that can be challenging, because you can ask 100 people, for what their common practice is. And I pretty much know that it's not a common practice anymore to clean your groceries, but people with OCD or highly anxious people are still doing that. So I feel like that need for the certainty is really is really challenging. And obviously there's a lot of other uncertainties going along with it, just about the world right now in relation to the virus. And is there a vaccine or is there not a vaccine coming soon? And just tons and tons of uncertainties. But that really stands out to me as a challenge right now.
Great, thank you. The next question is related to symptoms. So how, if at all, do you see the symptoms of OCD presenting differently among children, teens, and adults within the pandemic?
Yeah, I can address that. At first, and I would definitely welcome the other panelists' input. At first, I actually found that children and adolescents were actually doing better, and that they seemed to be being more resilient than some of the adults. However, as this has gone on and on and on, it just seems to be taking a greater toll, especially in this is the season in which school starts, and just, I believe, Dr. Saxena, it was you who mentioned that for teens and young adults, their peer group is essentially their family, right? It's their greatest source of support and connection. And to have that taken away, I think that that over the last several weeks, I've been seeing a big uptick in terms of isolation, the severity of depressive symptoms, even in people who did not have a prior diagnosis of depression. And also, just to piggyback on what Dr. Bergman was saying, I think the uncertainty of it all. I think if we are able to tell people this will be over in 3 months, okay, it's going to be painful, but we can make it work for 3 months. But this is open-ended, and we're talking about uncertainty. So that's one thing that I've seen in children and teens. The other thing that I have seen more, and certainly we saw this before, pre-COVID days, but people oftentimes think of contamination OCD as fear that the person themselves is going to become ill, and of course that's very, very common. But also in terms of contamination and on the spectrum of harm OCD, am I going to transmit it to other people? So I've had several kids come in, and they may have a parent who has a pre-existing medical condition, or they may an extended family member may be living with them. I've been seeing a lot of concerns about that. So I think it's affected the children differently. The other thing is, it's just the amount of screen time. So if the kids are spending X hours on Zoom or Teams or whatever platform doing schoolwork, and they're also doing treatment and programming, that can definitely take a toll. As I said before, as I wrap up here, that I am a perpetual optimist. So one thing that I have seen is that families are spending greater time together. They're exploring non-screen-based options, going old school, such as playing board games. I know I'm dating myself with that reference, which I think has been largely a good thing. So I think it is affecting different age groups differently, and I'm honestly concerned about what's going to happen over the next couple of months. As kids are, most kids in most places are out of school.
I mean, Dr. Johnson, I just want to echo a lot of what you said, is that, as a child and adolescent psychologist myself, a lot of the kids I've worked with, first couple months, they were like, yeah, no school, right? They're like, I'm out. Summer breaks, summer's starting early. And then as months went on, it is this, they've lost their family, their social network, their world, if you will. And you see that even some of the most neurotypical kids, that sort of like feeling of malaise or depression, or, just kind of bringing them down, especially the younger kids, they need more stimulation, they need more interaction. And this sort of virtual Zoom format that we're doing right now just really isn't doing the trick all the time. And then you have the lack of structure. You also have the stressors that the parents experience now, where they're trying to work from home and parent at the same time. And there is an impact on kids when that happens, like the kids can feel the stress from their parents, and they know that something's happening, and the kids can really kind of internalize that. And I had a session a couple of weeks ago with this 10-year-old girl who I've worked with for a very long time. And she was just like fidgeting and just like really just not being able to engage. And I said, hey, let me guess. You were in school all day today on the video, and the last thing you want is to spend one more hour on the video with me. And she goes, oh, yeah. And I said, okay, let's try to make this as least painful as possible. So it really is taking a toll on these kids. And but I agree with you. I love your optimism, Dr. Johnson. I've seen it too. So much more family time, a lot of, especially when both parents are working. Again, we're talking about maybe more privileged folks, right? People who can work from home, who have the luxury and the ability to do that. But in those particular populations, we have definitely seen an increase in quality family time, which is a very positive aspect of this.
Thank you. The next question, what are some local and national resources that can help support family and friends as they support a loved one who's been diagnosed with OCD?
I can address that. I think there are a lot of resources, and probably more than get publicized or more than we all are aware of. First of all, specific to people with OCD and related disorders and their family members, I think that the probably the best advocacy organization and support organization is the International OCD Foundation. major national international group, but they also have local chapters. So there's a Southern California chapter, there's a Northern California chapter, and both on a national level and on a local chapter level, they've got a whole variety of different activities. So we're doing this today because it is OCD week. Nationwide, OCD Awareness Week. And as you would expect, the foundation has a whole bunch of different activities that have been going on all week. They've been doing online town halls on a whole variety of different topics, including the effect of the pandemic on OCD, on related disorders like body dysmorphic disorder and hoarding disorder. They've done things on racial disparities, mental health problem in minority populations. They've done stuff that's specific to family members. So the foundation has a whole bunch of different support groups for people with OCD and related disorders. They have activities and support functions for family members, as well as stuff for clinicians. So they're a great resource. I think there are a couple other of these major national organizations, such as the Anxiety and Depression Association of America, the Depression and Bipolar Support Alliance. Many of those have support groups in different cities. I don't know the extent to which those have moved online and are available virtually, but I know other ones have popped up, and one of the advantages of doing things online is that you do have access to stuff happening all around the country rather than only in your local area, even though you don't get the physical contact. At least the support is there, and that is just vitally important for folks who already feel isolated and they may be ashamed of talking about their mental illness with anyone else who doesn't experience the same thing. And then the more general non-OCD specific stuff, like I was mentioning before about hotlines and warm lines. Many local communities have set up sort of mental health response teams in certain ways that are a little different than the suicide hotlines. They're more for just folks experiencing general distress. I think, unfortunately, one of the things that this pandemic has revealed is just how understaffed we are, and how much more demand there was already for appropriate mental health treatment, and that is dramatically increased, right? I mean, I think virtually any mental health clinician in the entire country can tell you that their demand and requests for treatment have skyrocketed for all the reasons we just talked about, and there simply isn't enough. And it's revealed the lack of a good public health infrastructure and a good public mental health infrastructure. So I'm hoping it'll lead to some change in the long run, but for right now, we've got limited resources and we try to, rely on the ones that we have available. And, in most places that I'm aware of, mental health clinicians are doing teletherapy for the most part. Some of them have gone back to doing in-person in certain communities where it's safer. But I really think people need to use these resources as much as they can.
Fantastic. Thank you so much. Thank you, everyone, for your insights and thoughts. Looks like we've got a couple of questions that have come in from the audience, so we're going to transition to those. This first one is for Dr. Park, and anyone can jump in addition. How would you differentiate between a transient episode and a diagnosis of OCD? Do you differentiate?
Well, I think especially when you're looking at kids and adolescents, they tend to be transient. I've worked with a lot of kids where, by the time they've come to me, they say, yeah, parents are like, they had a really bad summer that one summer, and then it kind of went away, so we didn't really do much about it. And then there was a little pocket of this and a little pocket of that. But now it's sticking around, so that's why we're here. And I think that really reflects that data that's shown that from the onset of OCD symptoms to the moment of receiving treatment, the average is actually 7 years. And I think that's part of that, is the fact that it's not that you wake up one day and it's like, boom, full blown OCD. It is oftentimes kind of in and out, where the entire nature of OCD, how we describe it, is a chronic disorder that waxes and wanes, right? So that is like the tagline, if you will, for it. So I think that when something may seem new or transient, I think it's worth being looked at by a professional to say, okay, what's going on here? Is this truly OCD, or is it something else? Because somebody can look like they have OCD, but it could be something else. It could be a trauma sort of a reaction. It can be a lot of different types of things. So you really do want to go to a professional and just kind of see like what's going on here, what's happening, what's the differential in those kinds of cases.
And I would add that anything that's going on, if it's interfering with functioning or causing significant distress, those are the two things you're looking for, then it's really worth going and seeking professional help. So those are two like key indicators that it's worth seeking help.
Yeah, if I could add, I think it's a really good question, and because the fact is that people have developed OCD symptoms who didn't have them before as part of what we call sort of COVID stress syndrome. And this has been found not only in our country, but around the world, that if you just take a look at the general population, including most people who don't have any sort of pre-existing OCD or other anxiety or mood disorder, there are classic symptoms that develop as part of people who have a great deal of stress and distress during this pandemic time. And some of those symptoms include classic obsessions and compulsions, contamination fears, fears of contracting or spreading COVID, checking compulsions, reassurance compulsions, and then some, what we'd call acute stress disorder symptoms as well. So yeah, so I think that question is getting at that point that yes, people can develop new onset OCD style symptoms. Now, it doesn't mean that they will go on and develop, what we would kind of consider kind of classic chronic OCD in the future. But as Dr. Bergman just pointed out, if it's causing distress right now, and it very often does, it may need treatment. Maybe that treatment will be shorter duration, maybe because they don't have as many predisposing factors, but maybe it might need to be ongoing.
This next question is for Dr. Bergman, but again, anyone else can jump in. How would you suggest I work with my child's school to help support her OCD recovery after she's out of treatment?
Well, it's a good question. If your child's out of treatment but still has symptoms, assuming if you think she needs help, it's never a good idea to work around the symptoms to sort of give in, or the jargon we use is to accommodate the symptoms. So let's say we always use the example of with contamination. It's not necessarily a good idea to use the same example all the time, because then it sounds like that's the only OCD symptom that there is, and it's not. But I will continue to do that. So let's say your child did have contamination OCD and there were still those symptoms. You don't want to ask the teacher to always allow your child to get up and wash their hands if they feel contaminated, because that's just going to perpetuate the OCD. But it would probably be better to have to work on this while you're still working with a therapist, but you're going to want the teacher or the school to be educated about the OCD and have a plan for what to do when your child is experiencing the symptoms, and help her cope with it and resist the compulsion according to some kind of predetermined plan. If your child is likely to maybe ask for reassurance or ask for a repeat of instructions or whatever it is, the teacher should be prepared for it and most likely not give in to the compulsion. But I would say that without knowing the details, it would be the most important for the teacher to be aware of what's likely to happen and have some kind of game plan to help the child resist the symptoms. Please, if any of my colleagues are.
Yeah, and I think Dr. Bergman, you made a good point. I think it's much better to start this process when the child is in treatment. I think post-treatment, oftentimes you think, well, if you're not in treatment anymore, then you probably don't need accommodations, and we expect you to kind of function, as kind of like a neurotypical kid. But, with a lot of my school-aged kids, one of the things that we would start off with, depending on the severity, is maybe we start off with a 504 plan and work with the school with like a really, really clear set that, hey, over time, this is going to shift and change. So if we, for example, if somebody had perfectionism and they were taking really long on their assignments and they weren't getting them in and they were failing because they weren't able to get it in, well, those kinds of conversations in school may start off with, hey, here, she's got OCD, so this is how we're going to deal with it now. But over time, maybe next month, like, let's give her breaks this month. Next month, let's do these different set of accommodations and everything. It's hard because we say in OCD, never accommodate. But then when you talk to the school, the technical term is called accommodations. Right. So bear with me, everyone, as I go through this. But essentially, whittling back on the 504 accommodations over time so that it aligns with the treatment plan, and making it very clear to the kid, hey, this plan we've got going on right now is not forever. The goal is for you to be able to do these things without the accommodations, without the extended deadlines or extra time on tests. And we're going to work on that together, me, you, and the school. And then and the school will be working with us jointly in that process.
Thank you. Dr. Johnson, how can I get my daughter into Rogers? She has severe OCD, and her therapist asked me to tune in and get her screened.
Fantastic question. So Rogers has really been working hard, especially in this COVID era, to reduce barriers to treatment because we know the urgency of that. So there are a few easy ways to get in. And I believe that these will, that we have a slide on these as well. There is a centralized intake number, so numbers for California, but also, being mindful that even though our clinics are in California, we have clinics all over the United States. So also a centralized number for them. And then also online, there's an easy way to access that and initiate a screen online. And then we would take some basic information, and that would be reviewed by our team to see if we would be a good fit for her.
Thank you. Dr. Saxena, I only have a few symptoms of OCD. Does that mean I have it, or do I have to have all symptoms?
So OCD can really vary a lot in its presentation. Some people have really just one major domain of OCD, but it might be anywhere from very mild to really, really severe. Most people with OCD have multiple different domains of symptoms. So let's say not only contamination fears, but also concerns about harm and danger that might lead to checking compulsions or repeating. Concerns about order and symmetry that lead to arranging and positioning. Sexual or religious obsessions, right? There's multiple different domains of OCD. It's a pretty heterogeneous or varied condition. And a given person might have one of those, or they might have a whole bunch of those. So we don't look only at what symptom is presenting. We're looking at, as Dr. Bergman pointed out, how severe those symptoms are, how much of an impact they're having on your functioning, whether they're disrupting your work functioning, your social life, your education, other health functioning. And we look at the chronology. So what's the timeline? What's happened before? Most people, I would say more than half of people with OCD had their onset in childhood or adolescence. And then the remainder maybe in young adulthood. So we're looking at a number of different factors, and we're also looking for other disorders that might explain those OCD symptoms, because occasionally people will develop a few OCD symptoms just as a part of a major depressive episode. And then when you treat the major depressive episode, the OCD symptoms go away. Or just as a part of generalized anxiety or panic disorder. So, it gets back to that question about if the symptoms are transient or they're brand new, how do you know exactly what the diagnosis is? That's what we have to do a full evaluation for, to look at all those different factors. So what really answers that question is an appropriate diagnostic evaluation.
Thank you. Dr. Park, is it typical for emotional numbness to be associated with OCD, and how do you treat that?
I think I'm gonna have to guess on what emotional numbness means. Maybe it's just kind of feeling nothing. If I'm gonna go with that, I think that sometimes can be an avoidance factor. So OCD can be very distressing and anxiety provoking, and can elicit a lot of different types of emotions, and not just anxiety. I've had folks who feel very depressed after doing exposures, who feel guilt or who feel disgust. It's a lot of negative affect. And sometimes, emotional blunting or feeling nothing afterwards, maybe it could be a part of, hey, I'm trying to avoid all these negative emotions that may come with this. And this is my coping mechanism. And I'd be curious, if this is how they respond to, if we start to do exposures, if this is how they respond to it, whether or not they progress through the exposures, because that could really help us understand, okay, so is this a part of emotional avoidance? Is this something else? How do we address it? What's the function of this? And really kind of get down to understanding where that's coming from and why it's occurring.
One thing to add to that is that blunted emotions, that experience of feeling like you're not feeling emotions as strongly as you normally would in the past. It can be related to lots of different things. It can be a medication side effect sometimes, right? Especially at higher doses of certain medications, they can take the edge off and even produce kind of an uncomfortable feeling of being apathetic or blunted. Sometimes it's simply part of a mood disorder like depression. And it can be part of other disorders too, sometimes as a response to trauma and PTSD, sometimes as part of psychotic symptoms. So again, you have to really evaluate what's going on and what's the whole context of what's happening for you emotionally to know really what it is.
Thank you. Dr. Bergman, what about perfectionism? My daughter feels she has to get straight A's, and if she doesn't understand, she has meltdowns. She will not guess on things. She also believes that if someone else is complimented, that means that she did it incorrect. Is this OCD?
It could be. Perfectionism is one of the domains of OCD. It's like we talked about earlier, in a diagnostic evaluation, you want to look at severity and interference and the distress. But because that is a domain, perfectionism is a domain of OCD, it's possible. You want to look at how the perfectionism is displayed throughout her life with schoolwork. Also, it's kind of tough with school. There is a kind of a emphasis in our culture on doing well in school and needing to succeed. So that drive to succeed needs to be looked at through that lens. And there is a certain amount of that it's normative, but if it really seems overblown, it is something to be concerned with. And to the extent that one of the things I always look for is whether the the drive to be perfect is actually causing the child to do less well in school. Like I've seen kids not turn in assignments because they're working on them for so long that they're then late or not handing them in because they're thinking they're not perfect, so they don't hand them in at all, or they're erasing things over and over so many times that they're destroying the paper, things like that, or melting down because it's not perfect. Remember a story of a kid, when you said about the compliments, getting so upset about another kid getting complimented that their glasses were nice, and saying like, I didn't get complimented on my glasses, and they didn't have glasses. So things like that, which I don't know if it's not being perfect, but maybe just having low self-esteem or something like that. In terms of the perfectionism itself, whether it's, getting really upset about getting a 99 versus 100. So you just want to look at how extreme it is to evaluate the perfectionism. And like I said, whether it's actually causing interference in the grades, and whether or not other things are impacted, like socializing, not spending time with friends because only wanting to do schoolwork, not having any other interests, things like that.
Yeah, I think that, I think the main theme here is that that these kids and these folks having a thorough evaluation is really important, because you want to understand the full picture, because perfectionism can also fall under generalized anxiety disorder. I know, and being in the Bay Area, we have really highly competitive high schools and schools in general, tons of pressure culturally and otherwise. I've had so many kids that I've worked with in the Palo Alto area who have told me, in order to be in the cool crowd, you have to get straight A's and be on the highest, path in terms of advanced and honors courses. I don't know about all of you guys, but that was not the criteria of being cool when I was in high school. So, things have really changed and the pressure is different. And what I've actually found is a lot of perfectionism in kids who have social anxiety, who are like, well, I need to do this really well so that I'm accepted by my peers. And I can't turn this in because what if they find out I didn't get a really good grade? And I think that can be a reflection of, again, social anxiety, maybe more GAD aspects, but also the culture of kind of the area that we live in and the high school that they go to and their peers.
Another thing I want to add is that sometimes I'll have parents say, oh, my kid cares too much about getting A's. And I'll ask the parent, well, how do you feel? And they'll say, I just tell them to try their best. And when I dig a little deeper, I see that no, the parent actually is giving messages that it's really important. Because then I'll say to the parent, well, what have you done in the past when the kid comes home with an 85? And they'll say, well, I sat down with them and we went over what they got wrong. And I feel like if you sat the kid down to go over what they got wrong when they got an 85, I feel like that does send a message that there was something wrong with the 85 if you didn't just say good job. So I think parents, if they're concerned that their kid is caring too much about their grades, they really should look at whether honestly they also are sending a message that a B isn't good enough.
Additionally, someone in the audience shared that they are on the spectrum and wanted to comment that maybe there might be some autism symptoms related to this. Does anyone want to comment on that?
Do you mean related to perfectionism or OCD?
Correct. Perfectionism. Mm-hmm.
Perfectionism. Well, I think that, with ASD and OCD in general, there is that overlap. We do see a lot of folks who are on the spectrum and also have OCD come through Rogers and have OCD elements and OCD symptoms. I think that in general, there's a rigidity in terms of those kids who are on the autism spectrum. And so when they might have an idea that it needs to be this particular way in order for it to be okay, Maybe that's an idea that they had a long time ago. Maybe it's a rule that they learned a long time ago that they've kind of carried on forward. I think I'd want to know a little bit more about, again, context, history, to really be able to say, how does perfectionism come into play with this particular individual who may be on the spectrum.
Fantastic. Next question. Do you feel OCD apps are helpful for teens?
Did you say apps?
OCD apps.
Oh,
Yes. Applications.
Anyone
can answer.
I've had, I think it depends on the kid and how much they want to utilize the app. I have asked some of the folks I've worked with to do it, and they hate it. And some people really love it and they implement it on their own. It really depends on how much they like to utilize their phone. I think monitoring in general is like a crucial aspect of OCD treatment, particularly in the beginning. It's part of our awareness training. And so we do want folks to write things down and really be able to get a sense of where their baseline might be at. And if an app works for them, great. If just putting it into their notes section of their phone works, awesome. If they want to go old school with some, pen and paper and a notebook and carry that around, great. I think it really depends on the individual and what they prefer to do, how they prefer to access their care.
All right. This question is for Dr. Johnson. How would you suggest seeking treatment for a 17-year-old son who does not want help and is unwilling to participate in any type of treatment?
That is a fantastic question and an all too common scenario. Especially, the work that we do, especially, the gold standard of what we call exposure and response prevention, is painful work, and it is work. And oftentimes people are reticent to engage in that work, especially teens. They may want to focus on other things. I think you can do a couple of things. If they are plugged in with a mental health provider, things such as motivational enhancement, motivational interviewing, to try to help them see the impact that OCD is having on them and what they're missing out on. I think that can be helpful. There are also some studies showing the intervention of reducing family accommodation in the absence of the patient themselves doing ERP. Now, ideally, we would do those in concert. However, our goal of that, and this can be hard for families, but our goal would be to make the OCD more inconvenient. Are there ways in which the family, with all the best intentions, with love, no one wants to see their family member suffer, and I can just do this act for her, and it's not that big of a deal. It takes me 5 seconds. It'd take her 3 hours. But by scaling back that accommodation, it might highlight the degree in which the young person is impacted, impacted by the OCD.
All right, and one more question for Dr. Saxena. I apologize. Do you ever see contamination OCD, which is not about germs, but instead about dirt, like dirt of floors, shoes, streets, garbage cans, car grease? I know something with that fear that the dirt travels to everything it touches, but it's not about germs.
Yes, all of the above. That description that somebody gave is a classic description that lots of people with OCD have talked about. So contamination concerns may be about just a general feeling of dirtiness. They might feel disgust that's triggered by Could be body fluids, could be dirt on the ground, could be something that they touch. Contamination concerns can be about chemicals, pesticides, asbestos in the wall, lead paint, industrial chemicals, any sorts of things, allergens. So these are just kind of general domains, as it has been referred to before, that could have all kinds of different specifics.
Did anyone want to add to that?
I'll just add, I've been doing this for so many years, and then I still just feels like weekly I'll meet somebody who has OCD symptoms that I've never heard of before, even contamination symptoms that I've never heard of before, like sand, or so just for everybody listening, there's always something that nobody else has had OCD about that you might have. So there's nothing that's too different or too weird that you might have or know has.
We actually had one more question come in, so I will, it's a little wordy, so give me a minute. Often parents contact me to work with their teen, and they primarily want me to work one-on-one with their teen, which sounds like I think they need someone outside of the family to talk with, and is certainly well-meaning. I'm curious what strategies are helpful to involve the parent and primarily educate the parent, particularly when the teen doesn't want them involved or is embarrassed by their struggles, but when it's also likely that parents either have little education around OCD or even more likely are being involved in the teen's compulsions.
Yeah, I can say a few words of that, and I would love to get the input of the rest of the panel. I am a firm believer in family treatment for OCD, and that can not just be teenagers, but for it can be a spouse, a loved one, a partner. It doesn't matter, because OCD never just affects that person. It's not just like a small little bubble. It affects the entire family system. And we have multiple studies which show that if you don't work on that family accommodation piece, you're just not going to get the robust response that patients deserve, and and I don't mean this in a derogatory way, but sort of the idea of just having the child come in for treatment, similar to be, dropping off a car to get repaired and you come back and pick it up. That has been shown not to be efficacious, that family involvement is critical. So if the team were saying, absolutely not, my parents cannot be involved, of course, exploring the reasons behind that. There might be some legitimate reasons, but barring that, I would really push hard for parental involvement. One of the things I love about Rogers is we have something called Parent University, which is basically a very well-designed course of psychoeducation for the family on what, well, in this case, OCD and anxiety. What does it look like, and how does it affect the family system, and what can we do to change that?
Thank you so much. Thank you, everyone, panelists. That's all the time we have today. Thank you, everyone on Facebook Live, for joining us and sending in your questions. We hope this was helpful in learning more about how to manage OCD during these challenging times. On your screen, you'll see that we're sharing local and national resource information, as well as our California clinic numbers and information. Thank you again to Drs. Bergman, Johnson, Park, and Saxena for your time and your wisdom. It's greatly appreciated. If we didn't get to your question, or if you have additional questions about the topics that were discussed today, please direct message Rogers on Facebook. And for more information on the OCD treatment Rogers provides, please visit rogersbh.org. And for helpful resources like videos and blogs, visit rogersbh.org/resources. Stay well. Thank you.